I didn't
tie
record
in
last lecture,
really
but I have
closely
those.
with a lot of the same concepts of coronary artery disease. If you have blockage in the vessels in your heart, it's very likely you have blockage throughout your body. So these patients often will have peripheral vascular disease as well as coronary artery disease. So a lot of the same concepts will apply to this. And there's some similar medications such as statins for these patients, but there are also a whole slew of different anticoagulants as well that we'll be talking about that are really important to know for safety. So let's look at our student learning outcomes for this topic. So safety, of course, is number one. We're going to identify and mitigate risks associated with vascular conditions such as DVT, such as peripheral arterial disease, and aneurysm, ensuring patient safety during diagnosis and treatment. A lot of these develop slowly over time, and they might not be treated right away, but there comes a point where the risk outweighs with interventional risk now becomes most important because there's a risk possibly of an aneurysm rupture, or the patient might have impairment of other major organs like the kidney. So we're always thinking risk-benefit, just like with everything in medicine, especially when we're giving medications. We're also, these patients often undergo a lot of different interventions. So safety in terms of assessing for any complications, and such as bleeding, infection, clot formation. So we're always, we need to have good assessment skills, and we need to know what's watch for, what's report, what's emergent, and what's not. Patient-centered care. So always specific patient information that we get from the patient on care. Over the weekend, I worked with one lady in clinical, and we had a patient who was undergoing an intervention. It was on Monday, this was the weekend, and he had, it was possible that he was going to be losing his extremity in the OR. He spoke to students and shared how he was not compliant his whole life. He's not that old, and now he's facing this drastic procedure. So there's a lot of things. Like with heart disease, there's a lot of disease. Things like lifestyle, right? Obesity, what we eat, our activity levels, all influence like this. So you can have occupations where you're on your feet all the time, nurses following this role, and then there's occupations where you're sitting all the time. So extremes of both of those are going to be for your vascular system. We're going to be providing education to these patients about vascular diseases, treatment options, and the importance of adherence. So if you're not adhering, likely your disease will progress. Professionalism, so the way we interact with our other multidisciplines, physical therapy, providers, families and patients, providing compassionate, and competent care to these patients is really important. We work with interdisciplinary team members in this area. Interventional radiology is a common place that they go with the our lab where they go for those procedures. So we're collaborating with those in those areas, making sure when we are giving report to those, that handoff report to those areas, that we include everything that's critical and important. A lot of that is medication related, NPA status, all that's really important. And then, of course, the foundation of everything we do is evidence-based. So the latest studies that support the care that we give. Alright. So conditions of the vascular system include arterial, venous, lymphatic disorders, and then we'll talk about cellulitis today. We need an adequately functioning cardiovascular system that ensures adequate tissue perfusion. So our vessels are just they're a freeway for all the nutrients, oxygen, those healthy things that all our tissues need to function. So we need a strong heart. So if you have a weak heart, that's going to affect your tissue perfusion. The responsiveness of the vessels. So as we know, as we age, we lose elasticity. So age, of course, is a risk factor. And then we also need adequate blood volume. If you don't have adequate blood volume, you're not going to be able to supply what you need. So there are several systems that are involved. It's not just cardiopulmonary system, but it's also our neurovascular system, our viscosity of our blood, and then our tissues' metabolic needs are also important. All right, so we'll talk about circulation. It all starts with the heart as the pump, and we'll go from just a quick review. Your left ventricle pumps out oxygenated blood into the ascending aorta, transfers to the descending aorta. We have all those branches that supply all our tissues and organs. And then we get to the very end of the arterial vessel, and we have our capillary network that then conjoins with our venous system. And we go from nice smooth coronary vessels to vessels with valves. Okay, and those valves are one-way valves that allow blood to flow back up to the left side of the heart. Okay, so you have your capillary network, and then you have the venous system, inferior vena cava, and it comes up and it empties blood into the right side of the heart. So that is the cardiac network. We'll talk about lymphatic vessels, so let's just review that for a minute. That's important. They're thin walled vessels that are similar to capillaries, and their job is to return lymph from tissues back to the bloodstream. So what do? They filter foreign particles and interstitial proteins, and they travel through that network, and they dump either into the thoracic duct or the lymphatic duct. You said it returns what back? Like fluid, particles, proteins, foreign particles into our ducts, and then they converge and dump right back into our bloodstream and into the internal jugular and our subclavian veins. Okay. So they act as a filter. So overall, that function of our vascular system, it's a supply and demand situation, just like with the heart, and they're delivering oxygen to all the tissues in the body. And it's dynamic, right? It's always changing, dependent on the needs of the tissues, right? And so certain things are going to affect that, like fever and activity. It is a broad category. Underneath that umbrella, we talk about all conditions that affect the circulatory system, the heart and the brain. Our carotid arteries supply our brain, right? And then our coronary arteries, our coronary tree supplies our heart. But otherwise, it's the vascular system. When we talk about peripheral arterial disease, it's that narrowing. So it's the same pathophysiology that occurs in coronary arteries, where you can have plaque buildup, right? So your diet influences it. Atheromas can occur, and you get a gradual increase over time, depending on your risk factors of inflammation, and then blockage is going to continue to build up over time. And so either one, a thrombus can occlude a vessel, and that has possibly an emergent system depending on lateral circulation. But you can have all of a sudden somebody who loses a pulse, the dorsalis pedis or the popliteal, they lose that pulse, and then anything distal to that is not going to get oxygen, right? And it's time is muscle, just like with the heart. And if enough time goes by, you can end up with necrotic tissue, gangrene, sepsis, and death. Right? So this is considered, if you have 100% blockage and there's no collateral circulation to supply those tissues, you can end up with necrotic tissue, right, with cell death. So that is potentially a surgical emergency, right? Something to report. You're going to look for, you're going to look for signs and symptoms. But if there's collateral circulation, if there is not a full blockage, and you're getting somewhat adequate circulation, it may not be a surgical emergency. Right? So there's many patients out there that this is just progressing slowly over time. So it's called embolic peripheral vascular disease, when a thrombus or clot suddenly blocks a vessel. And then there's something called functional peripheral vascular disease. And that's when it's not caused from a blockage, but from spasm. So like coronary spasm, we talked about Cranial's angina. So you can have spasm of your vessels. Can you think of a disorder where you get spasm and your hand turns? Your perfect in turn blue and then white and then Raynaud's disease. So that's a functional peripheral vascular disorder. Great.
Can you repeat what you said embolic peripheral vascular disease?
So there's embolic, and that's an example where you get that thrombus with suddenly blocks. And then functional would be where there's spasm. All right, what do you think is the biggest contributor to this? Smoking. So once again, you've got that patient, we talked about this with cardiac-urea, they come in with cardiac-urea, but they're smoking, they don't even have a pump, right? You're going to see progression of disease. Anything we do is not going to help. So similar with this. So smoking is the biggest risk factor we want to address in our patients for any reason, cancer prevention, all other disorders. But especially if they have this peripheral vascular disease. So, yeah, nicotine and tobacco decreases blood flow to the extremities. It increases, we got a sympathetic response, so we get an increase in heart rate and blood pressure. And the death rate is constricted, right? And secondhand smoke can contribute to this as well. Do you have a question?
I do. It's sort of just a confusion in my head and ongoing debate with my children, but smoking cigarettes isn't necessarily the problem. It's the nicotine in the cigarettes.
Correct.
So nicotine in any form is a problem here.
Yes, yeah, and I should make that clarification, because there's so many ways.
Yes, it's an ongoing debate with my 21-year-old. They have this in there.
All right, what are some other risk factors? If you have a history of any type of blockage or coronary artery disease, you are at risk for
That's a little dirty when I'm not clean.
If you have a trauma injury, let's say somebody has a war injury and they've got a blood trauma to their leg, they're at risk for different types of disease. So typically it's peripheral arterial disease.
So you said any kind of trauma at the leg.
So what are we going to see? What are symptoms of lack of oxygen to the periphery? So physical assessment, we're looking at cold versus warm extremities, right? We see paleness, we can see a pallor, we can see a rubor, we'll talk about when you see which. Loss of hair, somebody has no hair on their extremity, that's a sign of peripheral arterial. Brittle nails, thickened nails, drier skin, what we call eczematous changes. We call it a gator sign when we do discoloration of the skin. Atrophy and ulcerations. We're going to talk specifically about arterial versus venous ulcers. You can look at somebody's ulcer and know whether they have peripheral arterial disease or venous insufficiency. Okay? Palpating the pulses is important. What to do when you do this that pulse, what's important to know. And then all the different diagnostic evaluations, we're going to talk about that. There is an inflammatory marker that's a sensitive indicator of inflammation. Can you think of what that lab is?
The erythrocyte one?
Yeah. C-reactive protein. Yeah, this is erythrocyte. So that represents inflammation both systemically and locally.
What's the marker again?
C-reactive protein, the CRP.
Are you always,
So,
are you always gonna have inflammation with PPE?
it's like that, things like that, like with the heart. So yes, yeah, inflammatory changes occur. So let's talk about ischemia. So, in peripheral vascular disease, when the oxygen supply is insufficient, we have ischemia, just like we have it to the heart, and it releases adenosine. And that's a signaling molecule thought to affect nerves in these areas. And that leads to pain. So it's this signaling molecule adenosine that is what is causing the physical expression of pain. And we use a specific term. We talk about angina in the heart. Do you know what this term is for pain due to vascular disease? And often it happens when you walk. It's called claudication. Okay? So that's an important term for nurses to know. And that represents peripheral ischemia. Okay? And that's as a result of that adenosine molecule that's accumulating.
Wait. No. I don't need the word. What is the word?
Claudication is like angina.
Okay.
So it's like the physical pain specific to your colors. All right. And then we talk about rest pain versus activity pain. Okay, so what indicates higher level of disease? Rest pain, right? So they're not getting adequate oxygen at rest versus when they're walking or running, when the needs are greater, the supply is not needed with the hand. We can listen to these vessels, so in addition to palpating with our phone, with our fingers, we can listen with our stethoscopes, and we might hear a brewing because there's a turbulent blood flow as a result of the disease. All right, we should all be proficient by now at palpating our peripheral pulses, okay? And what are we palpating for? We don't count pulses from our feet, right? We're palpating for presence, amplitude, okay? Not even regularity, we're doing the radial. But we're just palpating for amplitude. Are they thready? Are they normal? Are they bounding? Right? So, our dorsalis pedis is on the dorsum of the foot. The hernia, which we typically don't palpate. The posterior tibial, which is on the medial, right distal to the tibia, on the ankle by the medial malleolus. So we're palpating right in that area. The popliteal pulse is an important pulse, and that's position that you want to be in there, and with your hands around the patient's knee, feeling for the popliteal pulse. 10% of the population does not have a dorsalis pedis pulse. Okay, so that's important just to be aware. Just if you can't find it, there could be edema, it could be deep, it could be, but they don't have that pulse. No, they don't have it. Yeah. So they have other, their other arteries are supplying the vessels. So if you see it, it's marked with an X, so let's say I calculate right here, where it is. I'm gonna put an X, that means I can palpate it. If you see a circle, that means it had to be gone, okay? And that allows you just to go right away, and you're not gonna spend 10 minutes trying to find it. It's kind of nice to take it. All right, let's talk about assessment. With arterial versus venous insufficiency. All right. So this is an important slide. There'll be questions on this content on the exam. So one of the first things we're going to talk about and ask our patients is about their pain. Okay, so we're going to physically assess, we're going to ask about pain. And for those with arterial insufficiency, they complain of pain typically when they walk. It can be obviously when they rest because then it's progressed. But when they walk, so they go for a walk and all of a sudden, that 2-mile walk that they do every day, they're starting to get pain in their calves, heavy feeling, and that's called claudication, right? Claudication pain. Exercise and activity makes it worse because their supply is not meeting the demand of the oxygen requirements during activity. If they stop, it gets better. Okay? They rest. And then typically, they have nice skinny ankles. There's no lower extremity edema. So again, when you're inspecting, you're not going to typically see edema. What you're going to notice is a pallor to the lower extremity. And in later stages, you see this ruby red color to the extremity, and that's called a rubor. And that's common with arterial insufficiency. We notice hair loss, okay? And it's not just from their sock line, and their skin is very shiny, and they show thick nails and rigid nails. So their nails have this change as a result of lack of oxygen.
So is claudication specific to arterial insufficiency?
Yes.
Okay.
So it's from ischemia, which is lack of oxygen supply to those tissues. Okay. People with venous insufficiency don't really complain of claudication, right? It's arterial insufficiency causing ischemia. Claudication. Somebody with venous insufficiency. So let's say, you're in a 12-hour shift and you've been standing all day long and your legs start to really ache and feel heavy standing for prolonged periods. And contribute to that as well as bring on cold. So if they're exposed to cold, they can cause a worsening of that discomfort. What relieves the pain? Elevating the legs, right? So think about that, and this is important to remember. With venous insufficiency, if you elevate the legs, the gravity is going to help with venous return, right? It's going to help the swelling, and it's going to allow blood, gravity's going to assist that blood flow back to the right side of the heart. These patients do have lower extremity swelling. And so the vessels just become damaged and they start leaking fluid into the periphery. You also see, anybody see this?
Yeah.
So this is what we call eczematous changes, and it's also called a gator sign, like how you wear gaiters if you go out getting your fish. So it's right in that area, right here. Okay. You see discoloration of the skin. So scaling, eczematous changes. Often you see, these little burst vessels from the pressure.
On the arterial side, what relieves the pain? Standing helps relieve the pain in
So
arterial.
stopping activity, yeah, so standing Yeah,
I remember at the Google clinic, they said, patients with arterial, problems at bedtime feel a lot of pain in their feet and their legs. The only way to relieve it is to literally stand up.
yeah. Yeah, and you're gonna have that patient at fall risk who's dying to stand up, right? And, or you walk by that room and the patient's dangling their legs over the side of the bed, it's because they're trying to relieve this pain, okay? That's how they feel better.
So they're trying to like get the blood flow back.
Right.
They don't know that's what they're doing, but that's.
They
what's
do it
happening.
like a natural response. It's like personal breathing for the COPD patient, they just automatically do it.
You don't elevate that one, right?
You don't, because if you elevate, now, you know, your heart's got to pump against gravity, right? So that's, make sure you understand that. The location of the pain can give us an idea with arterial disease, can give us a clue as to what vessels are blocked. If somebody has foot pain, it could be that posterior tibial artery or that perineal artery. If the pain is in the lower third of their calf, it's the popliteal artery. And the upper 2/3 of the calf, it's either the femoral or the superficial artery. You don't have to remember that, but if you just think about it anatomy, it does make sense.
Femoral or what?
You said femoral or what artery?
The femoral or the superficial artery. All right, let's talk about how a venous versus an arterial ulcer might look. Okay, so just looking at the type of ulcer, in addition to, you know, this other extremity looks, so you can see some pretty awful wounds. So let's talk about arterial. I talked about point of trauma, so somebody has a blunt injury or traumatic injury to their lower extremity, that can definitely damage the arteries. These wounds are painful. So these are the patients that you're going to want to pre-medicate before you do that dressing change, right? So, and you're going to use saline when you're removing the dressing because pulling on it is just very uncomfortable. Okay? Typically, arterial wounds are much deeper than venous wounds. And they're very circular. So you notice like a nice circle. That's more like the arterial. It's also a ruber. And there's some paleness to black areas, areas of necrosis possibly. So they're deeper and they're circular. And the extremities cool to touch. The pulses can be decreased, or you just can't feel them. You may hear a bruising. And they may have some neurologic deficits. So CSM. Venous, the most common area is on this medial malleolus area. So we're checking that when our patients with venous wounds. Neural pain. Okay. The depth is superficial versus deep with the arterial. And the borders are irregular versus that nice circular wound with arterial. The granulation is red to yellow. So we have seen that yellow. If there's a phlebitis present, you have some marks. And typically, you can still feel pulses. So these are the most common areas for venous skin ulcers. So just think of where that gate is. Let's talk about some of the testing that you're going to see. non-invasive way to visualize blood flow. We're listening for turbulent flow, release, it indicates disease. And it indicates moving blood flow, not necessarily tissue viability, right? So, just tells us the blood flow is moving. Exercise testing. So this is for patients with peripheral arterial disease. You can put them on a treadmill, see how far they can walk, or we might just do it because they usually can't walk very far. We map out, on a unit, or where they're having this test done, the number of feet, and you have them walk back and forth. And then we can take something called ankle brachial index. Okay, so we'll talk about that in a minute. I have a video. And we look at normals for that, and it tells us the extent of disease. So we'll talk about that in a minute. CT scanning. Angiography. So just like we do coronary angiography, we can also do peripheral vascular angiography. So somebody in this class, I believe, actually went to go down to the cath lab and watch a patient had a blockage in their popliteal artery, and they would go in and open up that vessel and increase blood supply. So they can they use angioplasty just like they do with the heart, they use stents just like they do with the heart, and then of course, so important, anticoagulation afterwards. So we'll talk about more about that here. MRIs are commonly done, venography, and lymphoscintigraphy. Those are all potential diagnostic tests that can be done. Okay, let's talk about this ankle brachial index. So this is done for several reasons. You might have a patient that's starting to have so it's evaluation for any leg pain that they're having. Maybe they're having pain in their buttock or their thigh or their lower extremity. They're having foot pain. They might have developed a foot ulcer. They may be status post some type of low extremity trauma, and they're considering there's some vascular compromise. And then it's also done is to evaluate the success of interventions that have been done, such as a stent placement. There are no absolute contraindications to this test. It's a non-invasive and objective way to diagnose peripheral arterial disease. It has a 99% sensitivity and a 95% specificity, so it's a good solid test. The patient ahead of time is told to not smoke at least 2 hours before, or caffeine. During the test, they should not speak, and they should rest for 10 minutes prior to the test. So we want good baseline pressures. Your cuff should be 40% of your limb circumference. The upper extremity cuff is going to be just like where you would take a normal blood pressure. And the lower extremity cuff is going to go right here. So where that kind of where that gator sign would be, if they had venous insufficiency. If it's mid-calf, it can be really, really painful, so make sure you're below the calf.
Sorry, is this just specific to arterial disease?
Yes.
Would you do it on someone that you weren't, is it like a baseline test for anyone with PV, like
So
peripheral
there would
vascular
be,
disease?
it's a screening test, but it's also like for, to see if, we're gonna get a score, right? We're gonna get a value, And it can show, progression of disease, it could show improvement after an intervention. So it can be done as a screening, it can be done to show progression.
I do it in my office
Do
that I'm
you?
working now, we
Okay.
just do it like as a screening, it's just part of the testing that we do.
Okay.
So it's interesting.
Yeah. Yes. Wound care, they do it wound care center? That makes,
Just to clarify, is it just for arterial?
yes.
Okay.
So, we get two systolic values. So you're gonna, if you've ever done a Doppler pulse, that's what you're doing. You're gonna use your Doppler to hear the sound of the pulse. You're gonna pump the cuff up to where you no longer hear it, right? And then you're gonna slowly release your pressure in your cuff, and 2 millimeters per second. So it's gonna slowly decrease, and you're gonna listen for when that pulse returns, that Doppler sound returns. Okay, you're gonna record that. You're gonna do it twice on the upper extremities and the lower extremities. Okay, you're gonna take the higher number, and you're gonna have your ankle index on the top, and your arm, your upper extremity on the bottom. Okay, so let's say your ankle index is 110. Okay, that's going to go on your numerator, and then you're going to do your upper extremity, and let's say that's 165. That's on the bottom. So we're going to divide the systolic, the numerator from the denominator, and we would get 0.66. So for 110 in the ankle, 165 in the arm, we divide that, and it's 0.66. So normal is about 0.9. Okay, so if the index, that systolic ankle versus systolic arm, is less than 0.9, that's considered abnormal. Okay, so this slide shows, this says 1.29.
Yeah, this is weird.
1.19 for the quarter line. Mild to moderate is 0.41 to 0.9. So mild to moderate PAD. And then, so 0 to 0.4 is severe peripheral arterial disease. Okay? So this is non-invasive, it's reliable. There's the first test to do to see kind of where they are in terms of the,
I don't think those values are right.
on there.
On there, only because, one, I just looked in the book too, but, because I think it's usually, it's 1.0 to 1.4 is normal. And it's in the chart, and that might be an old chart. I'm just,
Yeah, things.
Yeah.
I didn't recheck that.
Yeah.
All right, you know that, Romer, I can have you do one. So let's look at the video.
Choose a stable manometer cup of the appropriate size. This is placed over the upper arm. Palpate the brachial pulse and apply gel with the probe at the site where the pulse is felt. Place the Doppler probe lightly on the gel at a 60-degree angle towards the patient's head. Inflate the cuff rapidly until the brachial hardening flow ceases. No further Doppler signal. And continue for about 20 to 30 millimeters of mercury above this value. Following this, deflate the blood pressure cuff slowly at 2 to 4 millimeters of mercury per second in order to note the systolic valve. You can then wipe the gel from the patient's skin and repeat the procedure on the other arm. Following measurement of the systolic blood pressure in the upper extremities, measure the systolic blood pressure in the lower extremities. First, place the cuff above the ankle. The dorsalis pedis artery is located initially by palpation or identified by Doppler alone. No pulse is felt. You should obtain an arterial Doppler signal, which can be monophasic, biphasic, tri-phasing. Apply the Doppler probe to this area and inflate the blood pressure cuff to 20 to 30 millimeters of mercury above the level of flow cessation. Then slowly deflate the cuff until you hear the sound of the systolic pressure and record it. Repeat the procedure for the posterior tibial artery.
So obviously the lower the number, I would think the 0 to 0.4 you're going to have increased risk of wounds, if there's tissue loss, and ischemia, right? So the statistics I got for rest pain usually occur between 0.2 and 0.4. So this is another test, so angiography, they're using a dye, right? And so it's really important if you're diabetic, what medication are you holding for 48 hours if it's possible, metformin, right? And you're encouraging fluids after, you're watching renal function, making sure that the patient has tolerated the dye and it has not affected their renal function. So, here's an example of a peripheral angiography where they have opened up a vessel. So the same idea is, like I said, is with coronary artery disease using angioplasty and stents. And it can be very painful for the patient during this procedure. So you see them shooting the diaphragm. So you can see where the blockage is and then how it looks after they open up the vessel.
Is there a chance that we can? Never mind.
Also, if they are on anticoagulants, especially warfarin, you have to be really, really cautious. Their INR, which is specific to warfarin, it should be normal, so 0.91 for your INR prior to going through this type of test. It can take several days to bring that down. It has a much longer half-life than let's say heparin. So these are specific disorders underneath the arterial and venous vasculature umbrella. Okay, so there are MRI that can occur, and MRI, and then there's arterial insufficiency, and then there's also an obstructive disorder that are considered obstructive called Berger's disease. I'm going to slide on that. Under the arterial disorders, they include that functional vascular disorder, which is related to spasm of the arteries, and that's Raynaud's disease. And then there's vasodilatory disorders under that umbrella. And an example of that would be aneurysms. Okay. On the venous side, we have thrombophlebitis, which is obstructive, and we have varicose veins, which is vasodilatory. Okay, so we're going to be looking at those disorders. So if you're thinking about nursing process and care of these patients, sure you're thinking of like altered tissue perfusion, pain, risk for impaired skin integrity, knowledge deficit. Those are our main nursing diagnoses that are appropriate for these patients. So our goals, our interventions are all going to be geared toward improving outcomes for these patients. Major goals include increased arterial blood supply, promotion of vasodilation, prevention of vascular compression, pain relief, supporting good tissue integrity, and teaching them what they can do to for self-care to prevent worsening of their condition. we're gonna make sure these patients know how to protect their extremities, using proper foot care, keeping their feet covered. So similar to what we would teach for our diabetic patients. Regular inspection of their extremities with referral for treatment follow-up for any infections or inflammation. Good nutrition, with that diet, and then weight reduction if necessary. These are just orders under arterial. We're going to be looking at some of these. And we've already kind of looked at this slide already and discussed risk factors. So other risk factors we have not discussed include like hypertension. Hypertension increases risk for coronary artery disease. It also increases risk for peripheral vascular disease, diabetes, obesity, stress, sedentary lifestyle. We look at, in addition to the CRP, we also look at homocysteine, the elevations of that as well. Age, gender, and then familial predisposition is also a risk. We are, as far as interventions, making sure the patient's aware of positioning strategies. So they should be elevating their feet for venous disease, resting until pain goes away. I worked in a cardiac rehab program that did vascular, we brought vascular into our program. Patients would come in, we would put them on a treadmill. They would walk until they could not walk any further. And sometimes it was less than a minute when they first started out. And then they would sit down and rest until the pain would go completely away. They get back on the treadmill. They come back 3 times a week. They walk at home.